Okay, I think we will start. Good afternoon and welcome again to the third webinar in our series of 4 around value-based care. My name is Paddy Barkey. I'm the Marketing Manager at Coloplast Wound and Skin Care, and delighted to welcome Christine again. Welcome, Christine.
Thanks,
nice
Paddy.
to see you again.
Nice to see you too.
We had a great session last week, and I know you're going to sort of, in your 4th webinar next week, you're going to sort of wrap everything up, because we have covered a lot of topics, certainly in our last 2 webinars, all the way back to the quadruple aim and explaining a little bit about the NHS infrastructure and the new ICS systems from the 1st of July. And last week was really interesting about this motivational interviewing and the shared goal between the HCP and the patient, and finding out what does the patient want, obviously, to try and help their treatment. And you mentioned also about patient activation measures, so lots of new terminology to get our heads around. So this week we're talking about population health management, so looking forward to hearing, Christine, your webinar and lecture on this topic. And then we will be back, or I shall be back, in about 40 minutes when you finish, to just to facilitate any questions that the audience have. So once again, if you have a question for Christine, please enter it into the chat, and we'll keep an eye on that over the next few minutes, and bring those back to Christine at the end of her presentation. So over to you, Christine, and we shall speak later on.
So hi everybody. I always feel like when I start to talk about population health management, this is the hard bit. Last week was quite an easy bit to get your head around, but this is sort of at the heart of value-based care, really, is population health management. And I'm sure now that the ICSs are alive and well, that we'll start hearing much more about it. My understanding is that 40 out of the 42 ICSs have got teams working solely on population health management, so that actually we can begin to move things forward. Next slide, please. So let's not forget our little diagram of our triple stroke quadruple aim. We've covered many things on there already, and our focus for this week is improving population health and well-being. And I think the concept of the health and well-being as we move forward is really important in this. As Paddy said, next week we're kind of going to go full circle around this diagram and make sure that we bring all the bits and pieces together, things that you've asked for, and information and contacts that you might need going forward. Next slide, please. So let's not, it would be very remiss of me not to hit this one again, wouldn't it? And to remind us all, be that broken record, why we need to do this thing called population health management and value-based care. So let's just touch on a few of these things that are sitting in front of us now. Fact is, we don't have a health service. We haven't had a health service for some while. We have a sickness service. We deal constantly with sick people, and there is a need to kind of begin to move away from that. And because we deal with sick people all the time, we have hugely escalating costs of providing care, but we still remain in a world where there are budget constraints around that. We're experiencing issues around recruitment, retention, and I'm going to add in there retirement, because this is significantly affecting, I think, nursing and also general practice. And the next one, which talks about rising expectations, I think this is very, very different according to the parts of the population that you're looking at. So if you look at the rising expectation of the younger element of the population, then they are solely driven towards trying to access things quickly, access them digitally, not have to sit in a waiting room, just get a result now, because that's the world they're used to. And I think even in the middle tier, there is a movement towards that, but there's still a cohort of patients there that want to maintain access in the traditional way. And I think that's going to prove to be a massive challenge as we go forward. The other thing I want to touch on here is the fact that, You know, if you look at life expectancy, still for the affluent, it improves, yet for the most deprived, it has stalled or it has fallen. And that takes us into some of the concepts that Tudor Hart introduced many years ago around the concept of the inverse care law. Those that have get more, those that haven't continue to get less. Within that, we also have all the people that we're working with that are living longer with multiple chronic conditions, a big push around the world of frailty, and rightly so. One thing I would ask you to think about, particularly, we know there is a massive push around and continues to be so around the area of dementia. And I would draw to your attention, really, the fact that if you think about dementia and then you think about the area that many of us are working in now, which is that of our mobility, that if you lose your mobility, then your predisposition to dementia has got to increase because you end up on your own, spending more time on your own and isolated. So we mustn't lose the importance of the fact that mobility, physical activity, is a really, really important thing in keeping people well and healthy. And I slipped this other one in here. Public trust in the system is waning. There are kind of signals out there that people are getting agitated because they're on waiting lists, because they're not getting results, because they can't access what they want. And this is the first time ever that we're seeing that public trust in the system beginning to wane. And I personally think that's quite significant. Next slide, please. So today, a big question I want to ask you, those of you who are on today, what kind of mindset do you have? Are you a person that has a growth mindset, or are you a person that has a fixed mindset? And why this is important is today, I really need you to try and shift yourself into a growth mindset. And again, to maintain an open approach to what I'm going to share with you today. There will be some examples at the end, and they're just to get you off the starting block, to get you thinking. But I really need you to have an open mind as we go through this. Next slide, please. So, population health. Let me say it's not new. It's been around a long, long time, but it's never been so much in the frame as it is right now. And it is about describing an approach which is aimed at improving the health of the entire population. So not managing the sickness or the illness of them, it's about improving the health of that population. And underpinning this is big data. So you get access to the big data, which helps you to plan and guide the delivery of proactive care to get the maximum impact on population health. Now, let's face it, that is a million miles away from where we've been, which is why I need your minds in the growth area, okay? It's about collecting data and insights about the population's health and well-being, not just in one setting, but across multiple settings, care settings and service settings, to identify the main healthcare needs of the community and to start to reconfigure services to align with those identified care needs, okay? Key in this is the shifting of the focus from managing sickness to keeping people well. And that plays back to some of the things that we talked about in the previous two webinars. Next slide, please. It would be very remiss of me in that context if I did not remind you around the social determinants of health. Because if we're talking about keeping people well, and we recognise the fact that clinical care only has a 20% impact on the health outcome, then actually we are right smack bang in the important area of prevention, of patient activation, of coaching, of signposting, of understanding all of the other elements that come into play around your interface with patients. And I would actually advise you constantly to come back to this concept of the social determinants, because they play such a large part in a patient's ability to move forward from where they are and to grab the concept of the responsibility they personally have in staying well. Next slide, please. So, okay, I'll draw your attention to the little man sitting in the corner there with his bow tie on. And sometimes when I'm doing these sessions, it feels like this, you know? Tell us another made up story. We're all really interested. Well, do you know what, guys? This isn't a made up story. This is for real. This new shift in thinking is for real. And it's a tough road that we've now got to travel. And we will experience barriers. And there will be irregular steps there that we move forward with. But we cannot move away from the fact that we have to change the culture. We have to change mindset. We have to have collaboration at the heart of this. You know, I cannot even begin to talk about the number of times and how hard it is at times to bring community and primary care together. And that is the big starting point. That is where the rubber hits the road and it starts to bring a different thinking to things. The chance of trying to match service offerings to community needs actually means that people have to think and work differently, as it does if we have to move from reactive to proactive preventive care. I've put blah, 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 because I could go on and on and on about the importance of this. And I cannot emphasize to you enough that those key things that I've actually put on this particular slide are the things that are going to take us forward. Sadly, there is no magic dust to put on this. It is something we've got to do, and we've got to shift ourselves forward. Next slide, please. So let's go back a bit. The NHS long-term plan was very clear that by 21-22, we would have systems in place that would support population health management in every integrated care system across England. We're nearly there. Obviously, the timelines with COVID shifted things, but it's there in principle now. And what it's saying is there is a collective responsibility for managing resources. And I can almost hear you all saying out there, you know, we don't know enough about the resources. We don't know enough about where money's spent. We don't know enough about where we're positioned in contracting. But we have to find these things out to enable us to start to move forward and begin to actually position wound and lymphedema care as a force to be reckoned with and an area where change, it can significantly be made now. The other thing that's happening as a result of the NHS long-term plan and the new infrastructure is that move away from the commissioner-provider split. If you remember, it's created competition and it brought new organisations into the setting, but this is very much about we've got a system. How do we come together to make this work effectively for the best success for not just our patients, but also our staff? So 3 critical areas to making population health management work. The first is access to information. I want to almost say to you, data, data, data. If we haven't got the data to understand the population, how on earth can we make clinical decisions around what a service needs to look or act like? And I would put it to you that for many years, we have not understood the population we serve. We've tried, but we have failed to do it. Because understanding the population actually gives you the right levers to redesign care. We have for many years redesigned care in the dark. And that's where we're moving away from that. And we then are forced into areas of system and data integration. We have to share information across systems, across organizations, to actually allow us to redesign in the way it needs to change. And that means more at the front end. Some of you will be familiar with phrases like upstream rather than downstream. We work downstream. We work trying to solve people's sickness problems. We've got to get upstream and look at how do we stop them getting sick in the first place. With that information that we gather as well, we then start to truly gather clinical outcomes data. And I refer back to what we talked about before, is that move away from activity-based management to clinical outcomes. What is the result of what I'm going to do? Remember what we talked about last week? The joint responsibility of a clinician and a patient to have a shared journey with a shared goal. Your goal mainly is healing. I want to heal a wound in this period of time. I want to reduce the swelling in this period of time. The patient goal may be different around what they want to achieve as an individual, but you're both on the same trajectory, trying to achieve the same goal in the end. And that results in an improvement in quality, improvement in motivation, and believe it or not, lower costs, because we get there sooner. We can then begin to measure the impact of our interventions so that they become meaningful, and we can put our hand up and go, do you know what, we've got to do more of this because we know it works. And it's based on good evidence and robust analytics. And at the heart of this, and it has to be because primary care is the gateway in to the healthcare system, is our ability to actually motivate patients, as we've talked previously, enable them to become more self-sufficient, get into those high quality, low cost pathways. And here we move into the area of primary care networks and integrated neighborhoods is GPs managing larger clinical teams. For those of you who have already active in the area of primary care networks, you will understand these new roles that are coming into place to actually extend what's happening and perhaps give an opportunity for a patient, not necessarily to see a GP, but to see somebody else as an alternative, with the GP sitting further down the line as required. And some of this is because it is a fact we cannot fill the primary care gap with doctors because we just don't have enough of them. And of course, the other chestnut that's in there is the importance of development of digital, of technology solutions, and also remote monitoring in the home-based setting. And of course, in that, we also have to shift our focus outwards. We've got to stop looking in and navel gazing all the time. And we've got to think about the communities we're working in, the citizen themselves, and how we cover clinical and non-clinical patient needs. And I will say to you, there will always be a small minority of patients who use a disproportionate share of a healthcare, and they often sit at the top of our triangle, but we still need to deal with that. Next slide, please. And this returns us, as we look at the building blocks for population health management, to where we started at the very beginning of the webinar series on our infrastructure. That underpins how we move forward. The shared vision, mission, and the understanding of the journey we need to go on across an ICS, at place, and in the neighborhoods. That has to take us forward, and it needs to be underpinned by good governance. We have to have insight into what we're doing, which is what population health management brings. And it allows us to target and to segment and to start to look at risk stratification and to understand what we need to do in what part of the population to actually move us forward. We need the interventions, and this is about bringing forward primary care at scale. Now, primary care at scale is not just about bringing more practices together. It is about bringing the practices together with community, with other inputs, with social care, to actually get a much wider reach in terms of what we're trying to deliver. And that then brings new approaches to delivering workflow. I'm not saying to you at all that the management of wound and lymphedema care should sit in primary care, but I am saying to you that an aspect of it belongs there, and it's how it flows then into the community to create that seamless approach in and back out again. And of course, sitting at the top is the impact piece, is population engagement and patient activation. If the patient doesn't come to the party, we can't do this. It will not happen. We have to be able to take the patient with us and get them to understand the importance of what it is we're driving towards here. Next slide, please. So if I focus on the interventions part of that triangle, we have to look at workflow and how we optimize clinical pathways and begin to change how we work to get to more cost-effective interventions. I've just put a couple of things there. We're all aware of what's happening with virtual wards. Am I saying they're working well? I'm not saying that at all. What I'm actually saying is it is a concept we need to embrace, and we need to understand that you can't just plop a virtual ward in the middle of community services and go, come on, guys, let's get on with it. You've actually got to change how you work to make a virtual ward work. And the same applies to remote monitoring and anything else that we bring into that new way of keeping people in the community and stopping that flow of people into the hospital setting. This demands that actually clinicians get hugely involved in developing new care models and change the way of working. It has to happen in our own area of wound and lymphedema care. It has to, because A, we haven't got the staffing to cover it. B, the patient engagement in this is critical. C, particularly with lymphedema, it is a long-term condition and it demands patients' involvement in it because it is absolutely an area for self-management. We've got to strengthen primary care and deliver at scale because it's the one asset that we have, which is closest to the community. We have to get into data sharing. We have to have, every PCN has had to go into data sharing agreements so that practices now share data. They can each access each other's data. That is a massive shift forward. I can remember the days long ago where absolutely GPs would not share any data with anybody else other than people within their own practice. So that is a move forward. And we have to start to see population health management as a quality improvement initiative. I'm not saying go gung-ho, let's do all of this. We have to do it in small steps, and we have to take a project and we have to move it forward. That's what your quality improvement initiatives are all about, and you can do it. But that involves the mindset shift from this reactive way in which we work to a model of proactive care. And I know it's a massive challenge. I recognize that, because I can almost hear you saying to me, but how do we stop what we're doing to do this? You don't. You've got to start doing this with it and think about how do you get to that place. And it may well start with just finding 10 patients who proactively could work with you. Next slide, please. Last week, I showed you the primary care home model. This week, I'm going to show you what was called a multi-specialty community provider model. And this was done through the vanguards before we moved to primary care networks. If you look at the 4 levels of the multi-specialty community provider triangle, you can see it reflects exactly what we're talking about here. The bottom is looking at the whole population. And it's about how do we stop unhealthy behaviours? How do we continue to get people on board with that and to manage their own health? I mean, somebody read me something out this morning which made me smile, really. That in Greece, and you know, I'm sure this will tickle a few of you out there. In Greece, they're actually going to stop very overweight people riding on the donkeys. Now, that might seem like a very small thing, but I think it's quite significant. I think that will hit people and it will make them think, because actually, why would you want to do that to a small donkey that has this huge, great person sitting on them to go on a trip down the beach, whatever? Anyway, moving right along. So whole population. Next level is local networks of urgent care, using the new enhanced access primary care as the core model of that. So we all know that the new enhanced access in primary care comes into play on the 1st of October with extended hours in general practice till 8 o'clock at night and every Saturday. So that's a step, a real step forward. And that's about, again, stopping people going to A&E and stopping the chance that they may be hospitalized. You've then got your next level, which is the ongoing care needs, which is the day-to-day management of the system and the integration of primary, community and social and acute care services to make it work more effectively. You use risk stratification in these areas to identify which patients need which level of care, so that actually it's not about everybody getting everything the same. And I think that also is an important point. And of course, then we move to that small cohort of patients who use the disproportionate amount of care. And those are the people with the highest needs. They're never going away. And we've got to make sure that we develop strong care plans to support all of those people who are in that cohort and are at risk of unplanned admission, and try and look at how do we manage them in a community setting. This then allows us to start to reconfigure how the hospital needs to work to be the thing it needs to be for us moving forward. Next slide, please. So what I've done here is I've actually tried to relate this now to the area in which we are all involved. Okay, so it may not be the best thing in the world, but it's a starter for 10, this, guys. So if we push that across into wound care and possibly lymphedema as well, at the bottom there is the whole population again. So how do we start to prevent the problems that we have with lower limb care, for instance, because that's the area where it's easy to apply this, because it's such a big part of the cost base for management of wounds, if you look at any of the data. So how do we do that in prevention? And for this, it's at practice level for me. We understand all populations at risk of lower limb problems, cardiovascular disease, diabetes, etc. And we put those people into British Standard Hosiery so that we start to manage the swelling, and something is happening at that stage. We've then got the next level up, which is early intervention, again, at practice level. I was reading a service specification the other day that said, do not, if you are managing a wound in primary care, do not refer for 6 weeks until you've done everything you can. Well, I'm not going to say that, actually. I'm saying at practice level, we should, for example, be having a very timely response to things like your standard pretibial laceration. We all know what happens if you leave a pretibial laceration. Eventually it becomes an ulcer because you're just putting sticking plasters on it. My recommendation is you put a dressing on this and you put British Standard Hosiery with it, so you are compressing. And let's not get into the thought about compression at this stage, because we all know that the guidance that has come from the National Wound Care Strategy is very clear on the need to compress and not to be afraid of doing that. And I would again advise that you look at the guidelines from the National Wound Care Strategy for lower limb management. We then move into the area of ongoing care needs. That's where the TVN and community come in. So we get that flow from the practice into this area where your shared decision making sits, where you move your patient activation forward. Hopefully in the practice they may have done this and fed it through, where you look at your shared outcomes with your patients, and you focus here on not managing wounds, but reduce time to healing for the clinical side of things, because then you're reducing the cost base, you're getting people healthier sooner, and people start to feel better in themselves. And at the top is your highest needs. We need TVN specialist centres around the country that are looking at the complex comorbidities, are looking more at the significant impact of social determinants of health for people, and have multi-levels of complex issues that are being dealt with there. I hope that's making sense for people. It's very basic, but it gives you a thought process and enables you to think, what does that mean for me where I am? What do I need to do? Who do I need to be talking to? I would recommend to all of you that you're actually talking to your primary care networks, that you're actually trying to find out what's going on and what their approach to the areas of wound and lymphedema care are. I can tell you right now, and this sounds terrible, that lymphedema care is like, if you think wound care is a poor relation, lymphedema care is like even worse, because people go, oh, we don't do lymphedema. Well, do you do chronic edema? No, it's lymphedema. Well, actually, you know, we've got to get our heads around this, because the chronic edema, the lymphedema, that swelling in the lower limb is intrinsically linked to deterioration, to ulcerated legs. And for those of you, I'm teaching grandma to suck eggs, really, aren't I? Because we all know leaky legs often result in ulceration. So I won't bang on about that any further. I'm going now to take you to a different place around population health management, and you need to bear with me on this. It's not perfection, it's not scientific, it's very, very basic, but it will give you a flavour of what happens on the ground. Next slide, please. So here's a reality of calculating your current costs. I can't do the population breakdown because I haven't got access to data, but I want you to think carefully and really open your mind now. I want to share with you the fact that I've looked at Julian Guest's work, his latest work, and I've looked at the National Wound Care Strategy information. Now, in the Julian Guest work, he averaged cost of a non-healing wound. Oh, that's interesting. Some lymphedema services don't treat leaking legs. Oh, I'd like to pick that up later. So the average cost of a non-healing wound will work on 3,700. You can argue with me it's more than that. If it is, then it just makes this even better as an opportunity and an option here. So focusing here on wound care, looking at an ICS level, the average of a 7% adult population will have a wound with an average of 60% of those being non-healing. So these numbers are important. 7% of the average of 7% of the adult population will have a wound with an average of 60% of those being non-healing. In an ICS of 2 million, it is therefore likely that we will have 40,000 citizens with wounds, 84,000 of which will be non-healing. And at place level, remember we talked about place right at the very beginning. If we take the place level of 500,000, which is the top of the tree, 35,000 citizens will have wounds, and of those, 21,000 will be non-healing. And if you take it right the way down to the PCN level of 50,000, 3,500 will have wounds, 2,100 of those will be non-healing. So that's the Julian Guest perspective. If you move to the other side of this slide and you look at lower limb, including foot ulceration, the National Wound Care Strategy suggests that 1.5 of the population will have active leg and foot ulceration. Okay. If you look at the ICS of 2 million, 30,000, therefore, of which 18,000 will be non-healing. This is purely lower limb now and foot. At 500,000 place, 7,500, of which 4,500 will be non-healing. And at PCN level of 50,000, 750, of which 450 will be non-healing. And you can look at that bottom number there and think, oh, that's not very much. But actually, when you start to translate it, it is quite a lot. So can we go to the next slide, please? So I've now played this into some figures just using lower limb, okay? So let's look at our ICS, 2 million population. We've said 30,000 with 60% non-healing, and we've taken that 1.5% lower limb wounds, 18,000. The current annual cost for 60% non-healing at the average of 3,700 a patient is 66.6 million. Now, by anybody's measure, that is massive amount of money. If you multiply that by 42 ICSs, there is a significant amount of money being spent on non-healing wounds. That's bandages, the fact that the nurses are going in constantly to deal with these people and moving not much more forward than they were the week previous. If you do it at place level, you're looking at 16.7 million. And if you do it at PCN level, you look at 1.7 million on the figures that I've done. If you did it on different populations levels, obviously the numbers would be different. But I just wanted to give you a flavour of what kind of number we're talking about financially. So if I knew a PCN of 50,000 and we use these figures to tell them they're spending roughly 1.7 million pounds a year on average on non-healing wounds, how do we change that? My next question to all of you is, what is your art of the possible? And can you start to look and think about how you do something with these kind of figures? Because my guess is that by changed working practice, you can start to shave that down and savings can be made and working practice can be different. As I said to you, this is basic stuff that I'm giving you here. I'm not saying the figures are 100% accurate, but I wanted to try to give you something to hang a hat on here, to understand exactly just how much money is being spent in an area which is so opportunistic for making change at every level within an ICS and making a difference to not only the patients' lives and not only the clinicians' lives, but to resources in the NHS. This is population health management at a very, very basic level. If you knew all the data about the patients, you could do it even better. Okay? So, next slide, please. So, what kind of mindset do you have? If I've blown your head off with that kind of stuff, I'm sorry. But I think it's really important that we understand, that you go back and say, can I work this out? And if you can't, call me via Paddy and we'll work it out together, because then you'll start to see what your potential is and you can start to begin to build cases for moving this area of wound and lymphedema care forward. Bear in mind, those figures are only wound. That's got nothing to do with swelling. Those figures I've shown you today are pure wound care, non-healing wounds. That's the big ticket item that we've all got to go for. And so where you sit now in terms of this mindset bit, if you're sitting in a fixed mindset, I'm concerned. I'm concerned for how you see yourself in this new world in which we're going to work, because you really need to shift into the green head, into the growth mindset, and be open and think about, because you can't be not frustrated in this world. And if excuse me, if you're frustrated and you give up, what hope have we got? We've got to persevere and we've got to move this agenda forward, because if we as clinicians and those who care about wound care don't move it forward, nobody's going to do it for us, because it's not the big ticket item on the agenda. It's not cardiovascular disease. It's not diabetes. It's not any COPD. It's not any of those things that when you look at priorities, they jump right out of you. We've got to push this one and we've got to be willing to hold our hands together and move this forward. Next slide, please. So this is my final slide, by the way. So you're only confined by the walls you build yourself. And you know, I think that's such an important statement. You make your own constraints, but you need to start to think about what needs to change. Can you change it and how do you change it? I'm not suggesting you go banging down doors tomorrow and say, we need to do this. You need to get your case together, and you need to understand why it's important, and you need to be able to demonstrate that too. Are you driven to do it? I can understand if you think, do you know what, I've been doing this for years and I never get anywhere. You've got to give it your best shot. You've got to try again. We've got to go at this one more time, because the environment is different now and we've got the opportunity to do it. And the final thing is, where are you sitting? Are you a growth or a fixed mindset? I'll say to you, if you're a fixed mindset, this isn't going to happen, is it? It's not. You have to get into that growth mindset to make this happen. And, you know, as we move into our very last webinar next week, there are going to be a few challenges there. I can present all this till forever to you all, but only you can pick it up and do something with it. I can't do that. I'm not in a position to do that. I would love to be able to get hold of each one of you and say, come on, how do we do this moving forward? But we've got to get into that place and we've got to go for it. I've managed to stick with my 40 minutes, and I'm going to close it there. Thanks again, everybody, for listening. Take care. Hello, Paddy. Can't hear you.
Can you hear me now?
I can indeed.
I want to come back to one of the things you'd mentioned and it popped up in the chat was around lymphedema services and leaky legs. And maybe get your comments on, because there's a few comments in the chat about this. And is this a case of just the lack of commissioning in this area, or is there an easy solution to this? So what seems a big issue?
It's a big issue. It is a big issue. It needs a lot of flag waving. And in the main, lymphedema services are not commissioned. Okay. And leaky legs are like, you know, that old phrase, mind the gap. Leaky legs are in that gap. And the problem then you've got is if you don't deal with those leaky legs, imagine as a patient, if you've got leaking legs and somebody comes and bandages your legs and you're sitting then in soaking wet bandages because your legs are leaking. How horrible is that? But nobody's taking ownership for it, Paddy. But it is a precursor to leg ulcers, absolutely 100%. And it's very hard to separate the two. And we've got to campaign for lymphedema services, or at least strong chronic edema services along with lower limb. When we talk lower limb, that's why I keep talking about lower limb, because lower limb for me is wound and swelling. It's not wound in isolation. It's the two together because they're interlinked.
Yeah. And has the National Wound Care Strategy Programme focused enough in this area, or is that another area that needs, I guess, highlighting? Because I know it's been a lot around lower limb, which is venous insufficiency with diabetic foot ulcers, but I'm just trying to remember if there's sufficient focus or reference.
There's not really. There's not really. The area that's tried to deal with both sides of this is very much the Legs Matter campaign. Very much focuses on that. If anybody gets hold of their document, and I can't remember what it's called now, but I will, again, that's another thing I'll put on my list for next week. Read the document that they produced late last year or the year before, very strongly pushing forward on that connectivity between wound and lymphedema. And I sometimes want to stop saying lymphedema. And I know my colleague Julie Stanton's on here, and I don't know whether she'd slam me for saying this, but, you know, it's really important that people understand the chronic edema aspect of lower limb management and recognise that not everything's venous leg ulcer. There's a lot of lymphovenous stuff out there.
Yeah. I've got a few questions that I want to ask you. Thank you, Christine. Because there's one is, you know, I guess the data you've shown and how relatively, I'm going to say, make an assumption, easy it is to build into a business case. And I think people are very, I guess, worried that, you know, how do you request resources? Does a business case involve a very extensive, you know, 4,000 word argument? But when you show the numbers that you have, can you reassure people, like from your experience, what should, you know, if you're requesting resource and building a case for your argument, what's your experience of what a good business case and argument should look like?
Okay, there's a couple of things there you've touched on there, Paddy. The first thing is, and I'm a sado because I love this stuff. I absolutely love this stuff, and I love somebody putting a commissioner in front of me and getting me to argue the case with them, because at the end of the day, if you are confident and you can demonstrate, you can win. You might have to keep chipping away for a while, but you can win. But you have to have the confidence yourself to do it. And you have to have, when I say a robust business case, what I don't mean by that is the standard NHS 50-page flipping diatribe that you have to write, because nobody gets the end of it. They get past the first page and the board. So you somehow got to grasp some people's minds to get them on board with that and to actually start to move that forward. For you as an organisation, Paddy, I would say you need to be helping people get on board with this and understand how to articulate their case. But, you know, when you get a win, I don't know how determined people are, but I get a big buzz when I get a win with a commissioner. I love to get in front of a commissioner and for a commissioner to tell me wound care is not important, doesn't matter, doesn't know the figures, and you go, well, okay, I accept what you're saying. Just take a look at this. Let's just talk numbers. Let's not even talk a business case. Let's just show you what the numbers are. That's a great starter for 10. But you've got to feel confident.
Yeah, and that kind of leads me into next one about, you mentioned data, and I love your analogy about Willy Wonka, because I've always, because I question whether, are we entering the right data, or is the data just been lost in the system? Like, I think it was Augustus Gloop who got split up into little particles and was floating on the ceiling. That seems like what data is like in the NHS at the moment. It's there, but we've failed to draw it out of the system.
You see, I'm not sure the data that we want has been there,
Okay.
Especially when you look at population health management, because we haven't been doing it. I know loads of places over the years where I've been to, I said, let's risk stratify the population. And they go, how do you do that? What's that about? And we haven't done it, and we've got to start, even with our wound and lymphedema patients, we've got to get that triangle and put them into areas of importance and what that means and how they need to be managed. So the data hasn't been there. It's never been patient related in terms of outcomes, and we've never been driven for outcomes. All we've ever been asked for is activity data. How many? How often? You only have to look at how community nursing has to work. And I might get this wrong because I remember somebody telling me this. So if I get it wrong, I apologize now. But I believe they work in units of so many minutes. And you're not meant to overshoot that unit that you've got to see that patient, and you've got to deliver so many units in a day. Well, that's not healthcare. That's back to that conveyor belt thing that I showed last week. You're just going off the conveyor belt, patient drops off, done that, done that. And then what do you do when you get to the end of the day and you've still got 6 left? That's all the stuff that's got to change, Paddy. Yeah. It's got to. And we've got to start measuring the right things.
Okay, and one area that I guess a point to that, and some of the comments in the chat, is how to engage. You mentioned about primary care and the need to re-engage, I guess, the primary care and how the focus should be there because it's the point of entry. And what's, Joanna's mentioned it needs to quaff in GP land. What's your opinion on what's the key to engaging GPs in particular about wound care?
Okay, so quaff. Let's talk about quaff first. Quaff has a very limited lifespan now, okay, because quaff is being superseded by the enhanced services that are coming through a PCN. So what people need to understand is where the earning potential sat with general practice, some of that is being shaved off and moved into primary care networks, so as you get a much wider remit around what's got to be achieved. And what we've got to get GPs to understand is that number that I've been sharing, the 1.7 million on a PCN, and they would want to do something with that, but they wouldn't necessarily know how. And I go back to conversations you and I have had about the whole concept of prescribing dressings. It's not a familiar territory for general practice. It absolutely isn't. So we've got a journey to go on. Same with hosiery. GPs hate hosiery with a passion. 33,000 PIC codes. Hello, I don't want to do that, but it's not a familiar territory for them, and it's not been and they've never been paid to do it. So the primary care networks provide an opportunity. There's one of the private, the direct enhanced services for primary care networks this time round around inequitable care. And that's an area where people could talk to their PCN about focusing on wound care, because there's payment attached to that. I'll talk to anybody who's interested on what they need to do in that area, via yourselves or any other way, Paddy, because it's such an opportunity.
Great. Okay. A few other things. I don't know if there's a few more questions. Jamel had asked, certainly, on Coloplast Professional, we will put a link up just to share with you all of the previous webinars, and the recording for this webinar will be available on Coloplast Professional. So we'll pop a link in the chat so you can send that through to your vascular consultants, because she's saying there's definitely interest on that side, and to share your slides, Christine. Another question I have was, I was very interested to see, and it's these subtle things you see in the public press, because increasingly in the media, we've heard a lot more about social prescribing. And we also saw at the weekend, I saw a few articles in paper around virtual wards. So something is happening in public health that are beginning to seed through these concepts. Particularly, where do you see the role of social prescribing from that triangle you showed earlier on about general population health?
Okay, so social prescribing for me is the big ticket item. And I personally wouldn't call it social prescribing, because I think that terminology is wrong. What I'm talking about is wellness. Even those patients that we have not been well for a long time, how do we help them stay well? And to do that, we've got to have different conversations with them. You know, we have to get them to a place which actually enables us to say, understand your triggers, understand the things that get in the way of you making progress, and know when you need to don't wait till you've got an exudating leg ulcer before you ring us up and say, I need to see somebody. Do it earlier and say, I think it's going over. I need to talk to somebody. I need some advice. We need to get real good patient portals up and running that communicate with people. But our social prescribers, in inverted commas, are the people sometimes that people need to see before they get through to a medical person, because the issue is not medical. The issue is lifestyle. The issue is the environment in which they're living. And they just need somebody to talk to say, and that person can say, how do I help you move that forward? Then their clinical outcomes, if they are not well, will improve. And this is where we've got to get cleverer at how we're doing that. That's why I go back to motivational interviewing, because you identify things. That's why I go back to patient activation. And I feel like saying every home should have one. So every home, every service should have a health and well-being coach somewhere along the line that's actually working with the clinicians to take the patient into what I call a non-medical setting and to get them to think differently. Yes. It's the big thing. It's the big win if we can get it right.
Absolutely. I'm going to take you all the way back to the very beginning of your presentation, Christine, because I'm really interested in what you mentioned about prevalence and mobility and dementia. Is there any data around mobility, dementia, and wound care?
No. This is just me. I've always felt like this. You know, in forever the time I've been in wound and lymphedema care, and I've seen the number of patients that have passed through the clinics that I've been in, and I've thought, you know, and I've seen very sad people. Very sad, lonely people. And you look at them and you think, you can see where they're going to go with these, because nobody's bothered with them. You know, they've got a smelly leg, they've lost any respect for themselves, they don't care for themselves well. And we've got to lift these people up and move them into a different place, because as sure as eggs is eggs, the dementia thing they'll start to forget things. They'll start to, you know, lose their short-term memory and things like that. And what I'm trying to say here is we mustn't underestimate how important mobility is to people keeping well. If you can't walk out your front door, what's happening to you?
Yeah.
And so it's big for me. It's big.
Okay, I'm just wondering, is there any other questions? I'm just going to have a quick look at the chat box again. I think we have covered off most of the areas. As you say, next week, you're going to bring it all together for us, Christine. This time again, 12 o'clock next Wednesday. I don't think there's any more questions. I think we've covered everybody's questions. But again, if there are, we can answer them after this event as well. And as I mentioned again, all of this material will be available on Coloplast Professional. And today's webinar will be uploaded very shortly. So if there's no other questions, Christine, I'm going to thank you again for another engaging and really insightful presentation. And we look forward to speaking to you again and hearing from you next week.
See you all next week, hopefully. Cheers, Paddy.
Thank you. Bye-bye.
Bye-bye now.